Hello, everybody, and welcome. My name is Jess Posner, and I am the Director of Virtual Programs and Membership Services at the YMCA of Central New York. Thank you so much for joining us. It is my pleasure to welcome you to the second event in our month-long educational series with Syracuse. Hello, everyone, and welcome. My name is Jess Posner, and I am the Director of Virtual Programs and Membership Services at the YMCA of Central New York. Thank you so much for joining us. It is my pleasure to welcome you to the second event in our month-long educational series with Syracuse orthopedic specialists, which we will call SOS for short. Tonight's speaker is Lisa Mahon. She is a PA with SOS and will be speaking on bone health, osteoporosis, and what you can do to better take care of your bones. Our final two events in the series will take place Thursday, March 18th, 5 p.m. with a focus on the difference between bunions and big toe arthritis from Dr. Naveen Dugal, and Thursday, March 25th at 5 p.m. for staying active and injury-free this spring with Dr. Todd Battaglia. Please note that these events do require separate registration. If you have any questions or would like some assistance, feel free to contact me at virtual@ymcacny.org. We will be sending a follow-up email to everyone who registered for this series, and those will include those registration links as well as other useful information. Before we officially get started, I'd like to offer a little virtual housekeeping. First, you will notice that you are automatically muted when you entered. This is to help maintain a pleasant experience for all. You will have access to the chat, so please feel free to enter your questions there at any time. Feel free to have your cameras on or off, whatever feels good for you. I will be spotlighting our speakers, which will highlight them on your screen when you have the presenter view selected. To turn this on, please click in the upper right-hand corner of the Zoom window and select presenter. Your other option is gallery, but you're looking for presenter. After Lisa Mahon has finished her presentation, we will have time for a moderated question and answer session. Please feel free to type your questions into the chat at any time. I will be monitoring it and will share them with our esteemed guest at the appropriate time. Several of you shared your questions for our guest via email, which have already been shared with her, or I've got them ready to go for our question and answer session. So without further ado, it is my pleasure to introduce Lisa Mahon. Lisa Mahon is a physician assistant at SOS with a focus on total joint replacements and hip and knee problems. She also has a strong interest in diagnosing and treating people with osteopenia, osteoporosis, and vitamin D deficiency. She earned both a BS in physician assistant studies at Lemoyne College. She is licensed as a physician assistant by the University of the State of New York, Education Department, Office of Professions, and is board certified by the NCCPA. Lisa, welcome.
Okay, thank you so much. So happy to be here. Osteoporosis is a condition in which the bones become weak and brittle. Almost 54 million Americans are affected by this disease. 1 in 2 women and 1 in 4 men over the age of 50 will break a bone caused by osteoporosis. Something we don't think about or realize is that our bone is alive. It is constantly turning itself over. We have cells that are responsible for building the bone up, called osteoblasts, and we have cells that are responsible for breaking the bone down. This is just a visual depiction of the osteoporosis. A healthy bone on the left and osteoporotic bone on the right. One of the things I hear a lot about is from patients, they're confused about osteoporosis versus osteoarthritis. They're actually two totally different things. They're not related at all. Osteoporosis is deteriorating bone mass. Osteoarthritis is degeneration of the cartilage off of the joint. The depiction below that osteoarthritis headline there shows that the white articular cartilage over the bone wearing away is a good example of what osteoarthritis is. Osteoporosis is known as a silent disease. It does not give you pain or aching or anything until you develop a fracture from it, or until you start to develop a kyphosis. And that results after you've had compression and wedging of the spongy bone in our spine. And that occurs as a result of osteoporosis in that bone. Unmodifiable risk factors. The big one is genetics, family history. If you've had your mother, father, grandmother, or grandfather with osteoporosis, you are at higher risk. Being female puts you at risk. White or Asian race puts you at risk. Thin, small frame, or low body weight. Early menopause before age 40. Certain medical conditions, and there's a lot of them. Thyroid abnormalities, vitamin deficiencies, vitamin D deficiency is a big one. Chronic diseases such as rheumatoid arthritis, lupus, MS, celiac disease, even diabetes and depression have links to osteoporosis. Many medicines can cause osteoporosis. The corticosteroids are the big one. And then certain types of cancer and cancer treatments affect our bone quality, and other conditions that affect our ambulation, such as a stroke. Risk factors that are modifiable, these are the ones we can do something about to improve our bone health. Alcohol use is a notable risk factor for osteoporosis. There have been some different guidelines on this. Recently, federal guidelines have changed. They consider moderate alcohol use as 1 beverage daily for women and 2 for men. It used to be 2 for women and 3 for men. Heavy alcohol use is now considered anything more than 1 a day for a woman and more than 2 a day for a man. Smoking is one of the worst things for your bone density. If you've done that at any point in your life for a period of time. Excessive caffeine intake is a big one, and we don't often realize that, but that can really affect our bone quality. Chronic soda beverages also affect our bone density. The phosphoric acid in this has an effect on our ability to pull calcium into our cells and to our bones. Carbonation is questioned whether this affects our bone quality as well. And then the caffeine in soda beverages also has an effect on calcium absorption. Lack of regular exercise, a very sedentary lifestyle is a risk. Diet low in calcium and vitamin D, poor nutrition, poor health, excessive dieting, and athletes without a menstrual cycle that is regular for a younger female, that's a big one. Why do bones break in certain areas and not others? You'll hear many stories of people who have fractured their hip. It is a very common thing, and we see it all the time. Parts of the bone, cortical bone is the stronger type of the bone. It's compact. It's found in the shafts of our bone, and it makes up about 80% of our bone mass. Trabecular bone is the other type. It's also called cancellous bone or spongy bone, but it's more porous. It has lower calcium content. It has more water compared to cortical bone, and it's found in, if you look at the picture here on the screen, it's found in the neck of the femur. And this, at the top of this femur bone, is where our hip joint is. And that's where we see a lot of our fractures. This is a visual depiction. On the left is a femur fracture, and that is considered the hip joint. And then on the right is a picture after surgery to repair the fracture. And it's not great quality, but it gives you an idea of what is done. Vertebral compression fractures, you'll hear about compression fractures or fragility fractures. We will call something a fragility fracture if it occurs for no reason, no injury, no activity at all. Very common. We will see these in the spine. On the left here, you'll see a imaging of the thoracic spine. And right in the middle here, you'll see this wedging of the vertebral bone, which is a fracture or a compression fracture. On the right here, there's an X-ray of the lower portion of the lumbar spine, and there's a compression fracture here in this vertebral body. So how do you diagnose osteoporosis? The gold standard test is called a DEXA scan. It's actually a type of an X-ray. It's not a bone scan. People hear the word scan and they get confused thinking that it's a bone scan, and that's actually a different type of a test. Calling it a bone density test is the safest thing to do. That way we know what it is and who's ordering it and checking it. Who should be having this? Any postmenopausal female. Ideally, you're getting a test to bone density, and you're doing this right at menopause, or if you have significant risk factors, you're getting one menopausal. With males, if you have any notable risk factors, you should be getting one checked at, and then you'd use that to compare down the road to see what the bones are doing. Anyone with a low velocity fracture or fragility fracture, and anyone with 2 or more risk factors. So things to know about the DEXA scan. It ideally should be done in the same office on the same machine, if possible. Insurances will cover this every 2 years. Bone quality does not change quickly on the DEXA scans, so you really wouldn't need it any earlier than every 2 years. In some cases, if you had some serious condition, maybe once a year, although you'd have to get that pre-approved with the insurance. But the mathematical measurements that go into doing these tests, if the machine is different, it's not a perfect comparison from one machine to the next. It'll still tell you something, but you'll get a better idea of if the bone quality is changing for better or worse if you actually have the test 2 years apart on the same machine. It measures the bone mass in 2 to 3 areas, the spine, the hip, and the wrist. The bone quality starts to become worse in these areas, first with the spine. Significant osteoarthritis in someone's spine will negatively affect, or I actually take that out negatively, it will affect the bone density scores. The arthritis will give you scores that are higher than what they should be. So if I have an 80-year-old who I know has severe osteoarthritis in their spine, I really won't pay much attention to the DEXA scan scores in their spine because I will know they're not that accurate. Osteoporosis on the scoring of this test is any T-score at -2.5 or less. Osteopenia, which is beginnings of osteoporosis, is a T-score of -1.5 to -2.4. The best way to treat osteoporosis is to prevent the bones from getting weaker than they are or thinner than they are. Prevention is key. Calcium and vitamin D supplementation. There recently was some controversy, you may have heard about it in the news, where I can't remember if it was 1 or 2 studies, but they were really questioning, is calcium helping people? Is it effective? They ended up deciding that you need to be checking to see what your specific intake of calcium is daily. So if you are getting in 1,000 milligrams to 1,200 milligrams daily in your diet through your food, you really probably don't need to be taking a calcium supplement extra. Most people are not getting anywhere near 1,200 milligrams of calcium through their diet unless they're a very, very big dairy person. Calcium is absorbed in smaller doses, so you shouldn't take 1,200 milligrams all at once. You should take it 600 milligrams or less at a time. The types of calcium, they're both good. Calcium carbonate, they say you should definitely take with food. Calcium citrate, you can take it with or without food. It's supposed to be absorbed either way. However, it tends to make you nauseous if you take it on an empty stomach, and it may not be as well absorbed without food. So bottom line is really just take it with food. Vitamin D is very important. The two together, calcium and vitamin D, they go hand in hand. If one of them is low or not working effectively in your body, the other one won't work. So the D's job in this case for calcium is to help transport it into the bones. It has many other important roles. You'll see a lot of different numeric recommendations for daily D intake. 800 international units up to 2,000 international units for an adult. If you are a postmenopausal female, my opinion is that you should be doing 2,000 international units daily. If you get a lot of sun and are outside a lot through the summer, 1,000 international units a day is reasonable. If you live in this area year round, sorry about that, the vitamin D that you would absorb from the sun, we don't even get that type of sunlight in this area in the months of November through March. So in this area through the winter, I tell everyone at least 2,000 international units a day. If somebody is deficient in vitamin D, of course, then you go up higher on the number, and there's a few different protocols that providers have for treating that. Who should be given prescription medication? So it's interesting because it really does get down to a person's specifics, their own risk factors, their bone density scores, and their medical background. If they have a significant history of GI issues, they're not going to tolerate certain types of medicine that you want to give them for this problem. The other thing that needs to go hand in hand with the bone density test is blood work. You should always have your blood work done to check your vitamin D level, calcium, thyroid, parathyroid, etc. There's a big chunk of them that should go with that. And before you start a medication for osteoporosis, you need to see that the person's calcium regulation is normal, that their body's processing things normally. If I often come across someone with a significant abnormality, we'll refer them to an endocrinologist because that's their specialty. They can take care of that certainly more effectively than us. Vitamin D deficiency is rampant in this area, but it is questioned. If the vitamin D is deficient, a prescription medicine for osteoporosis may not be effective. So you really need to make sure your vitamin D level is at a reasonable level in order to have the medicine working for you. The number one type of medicine for osteoporosis, they call them the bisphosphonates. I'm sure you've all heard of them, Fosamax, Actonel, Beniva. They inhibit the breakdown of bone activity, the osteoclast activity. Reclast is an infusion. Prolia is a different type of medication. It is an injection that is given twice per year, I believe. It helps stop the development of the bone, the type of cell that breaks the bone down. Forteo is another one. It's a synthetic hormone that helps regulate calcium metabolism. That one is quite effective, although there's bigger risks with it, and you'll usually have a specialty person prescribing that, someone such as an endocrinologist. So prevention and things you can do, even if you have osteoporosis or osteopenia, moving. The best thing is weight-bearing exercise. The easiest thing in that category is walking. Wrist weights while walking is preferred because the bone that we forget about is our humerus bone, which is our upper arm bone, and that is at risk for osteoporotic fracture. A lot of people that I see don't tolerate walking. Your next best step is you go to a consistent exercise program with weights, chair exercises with weights. Exercise at the gym with a weight machine is wonderful for your bone density. Water exercise with water weights is okay. It's not as good as the weight-bearing exercise because you're not getting that impact that helps strengthen the bone. Walking against a current in the water is pretty good. The Y at Baldwinsville has a really good river current to use that, and if you walk against that, that's a pretty good workout for your bones. The water weights, I'm not sure if they actually have water weights at the Y. They may, but those in the water are very helpful as well. I put this on here because a lot of people look at me funny. They're like, what are you talking about, wrist weights? But the picture on the left is a picture of a pair of wrist weights. You literally wear them like a bracelet. You can get 3 pounds, 5 pounds, and go up from there. But really, most people, I tell them just start with 3 pounds. And when you walk with those on, you do the power walk type maneuver. And that is what is really good for the upper body bone density. And that is it. Any questions?
Thanks so much, Lisa. If you want to go ahead and stop screen sharing, what we can do is open it up to any questions from our audience. I'll go ahead and spotlight myself here too, so we can have a little conversation. So does anybody have any questions that they'd like to submit? Please go ahead and type it into the chat box, and I can read those to our guest, Lisa Mann. And feel free to go ahead and send those in. I actually had a couple other questions from folks that came through email today, but you answered them all in your presentation.
Good.
You did.
Yeah, most of them were in there already, but not all of them.
Yeah, absolutely. So, I mean, I guess to just get the conversation started is, do you have like other things that what are some of the most common things that you see coming into the office, in the last year or so?
Well, that's a loaded question. We've become very busy with the orthopedic arthritic aspect of things that I've actually had to not do as much osteoporosis treatment work. So fracture wise, by and far, it's always a hip fracture. That's the thing you see so much. Do because it is so common. But that's the biggest type of fracture we'll see relating to osteoporosis. Yeah.
What kinds of advice might you offer to people who are nervous about coming into a doctor's office because of COVID right now?
Well, the good thing is that most of my office is, I think we're at over 90% vaccination, fully vaccinated in our office here, which is great. And if you can have both of your COVID vaccinations, I don't think you should have any concern at all about coming to the office. If it's not your turn to get vaccinated yet, or if you haven't received them yet, we're pretty safe. We actually have our waiting room laid out where everyone is still 6 feet apart. Everyone has to have their masks on. We're family members or anybody to come in with the patients just to minimize the amount of exposure. And our patients are checking in through their phone in their car. So they're bypassing the waiting room, which is nice because it keeps you from being in one area with a lot of people. Yeah.
Oh, thank you so much. Those sound like a really incredible kind of precautions.
Yeah. 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 We're doing a good job.
We've got a few questions that came in. One from Joan, who says, I thought walking with wrist weights was not recommended. I've had surgery on both rotator cuffs and I'm worried about re-damaging them.
Yeah. So the wrist weights are great for your bone density. They cannot be great for rotator cuff tissue that is a little weaker. So if the shoulder doctor advised against that, you listen to the shoulder doctor and see if there's something else you can be doing as an alternative. Yeah, the rotator cuff tissue probably trumps that problem.
Would you recommend probably getting in touch with a specialist to give them a specialized course of care?
Yeah. The in the gym there are the machines. I mean, I say it's a gym, but my God, no one wants to go to a gym in the pandemic. But once we feel safe to go to a gym, the weight machines, believe it or not, are actually very good. So if you have a shoulder issue, they say it's safer to use a machine. Don't do free weights. Don't do the weights on your wrists. And you'd have someone show you, but a very low weight, symmetric type of thing where you're doing, like, say, your press, but that type of a resistance exercise is good for the bone density of the upper arm.
Wonderful. Thank you so much. And just to let you guys know, we do have a really robust personal training program at all of the YMCAs in Central New York. So if that is something that you're interested in getting in touch with, you can shoot me an email at virtual@ymcacny.org, and I'd be happy to connect you to a personal trainer at your branch. All right, we got a few more questions coming in. From Kathy, if bone loss is due to Dilantin, will the bone recover when one stops taking it?
Oh, Dilantin, that's a seizure medicine. It's also used for other things aside from seizures. My understanding is no. Once the bone quality becomes affected, if you stop the medicine, the bone does not go back to where it was. There are many things you can do to help improve your bone density, of course, which is the exercise, weight bearing exercise, the food, and the prescription medicine if the bone density scores are bad enough.
All right, thank you. From Joan, we have a request for your favorite high calcium food choices.
Salmon, milk. You've really got to be a dairy lover to get your calcium. If you don't, you should be taking the supplements. But there's a Fairlife milk I love because it's much higher in protein. It's got a nice amount of calcium, and then it's lower in sugar, and it's lactose free. But any type of milk, almond milk is wonderful.
Thank you. A message from Sharon says that they are taking alendronate. I'm gonna mess up the pronunciation just because I'm not a doctor. Tabs at 70 milligrams. How many years should this be taken?
That's a debated question now. So we used to say, okay, you should take this type of medicine for 3 to 5 years and then be done, max. It's a little gray now on whether that's true. I think most providers still abide by that rule where they say, okay, you do this for 5 years, we monitor your scores, and then you take a break, and then keep monitoring the scores. And then at some point, if the scores get worse again, or do you restart the person on this medicine? If the scores aren't improved much, you probably would also just consider going to a different type of medicine, not the bisphosphonates, the alendronate class.
We've got another question about some milks and non-dairy milks, and wondering if you were to get around 900 milligrams a day through non-dairy milk, if that is enough calcium, in your opinion.
That's a nice amount. It depends on your age. So if you're in the postmenopausal female range, you would still be striving for that 1,200 milligrams of calcium a day. And of course, you're taking it throughout the day, which is nice because you're absorbing it. It's absorbed best in small amounts. Did I answer the question? Yeah,
I think
so
so.
900 is wonderful. 1200 is better. You maybe would throw in a little supplement if
Or
you
maybe
wanted
another
to.
glass of
Yeah,
milk.
yeah.
Does exercise improve T-scores?
It can. Yeah, it can, but there's a gray area of how much exercise. So it really is that specific. You look at the person, their risk factors, their family history, and all the other stuff. If the person did 20 to 30 minutes of walking 5 to 6 days of the week, and then maybe even threw in some weights for the ankles or wrists with that, I mean, that would dramatically help their scores. Yeah.
Thank you.
Mm-hmm.
We've got a couple of questions about fear around the side effects from some of the osteoporosis medications.
Mm-hmm. Yeah.
So I was wondering if perhaps you could help, perhaps just like talk us through how you might talk to a patient to make a decision around if the medications are
Mm-hmm.
good for them, considering the side effects that the medications may have.
Mm-hmm. Yeah. A large amount of side effects with the bisphosphonates, which are the most common ones, the Fosamax and those. Though if it's an oral pill, the big issue often is GI. It can upset their stomach. It can irritate their stomach. It can make them nauseous. It can questionably, this is again the lovely thing of medicine, is that things can change. So for a long time, we thought that if you took these medicines, you could be at risk for stress fractures in your femur. Now it's questioned if that's actually true or not. Is it the medicine causing stress fracture, or is it their pre-existing osteoporosis doing that? Or so that was a definite thing that orthopedic surgeons thought and did not like the medicine because of. But now there's some things that have come out to say, maybe it's not actually the medicine doing that. So
Thank you.
The side effects of the injection of the medicine, bone pain can often be one of them. The other two non-bisphosphonate ones I'm not as familiar with, only because I don't prescribe them, but I see plenty of people who need that type of medicine, and we refer them to specialists.
There was a specific question about the injection, and they said that if you do have severe side effects to things that are not tolerable after you've taken an oral pill, you can stop it. But with the injection, if those side effects may last months, are there ways of treating that, or how do you deal with those side effects at that point?
I'm not as familiar with the injectables because we do not give them here. I don't know the answer. Would you potentially experience side effects for months from that one injection? I don't know. Yeah, that's one of the reasons we don't get into that, is because we already have such specialized things we do. We usually send the person to an endocrinologist.
Thank you. A quick question, if you could just refresh us on the recommended levels of vitamin D under the different circumstances of our sun exposure.
So most people, 2,000 international units is the easy answer. You would have to try very, very hard to take too much vitamin D, unless you don't live here. But if you live in this area, you are never going to get too much vitamin D. The people who are deficient, we actually give them 50,000 international units for treatment. So 2,000 a day is a good number.
I've been on 50,000.
Yeah. So it really, and there are some other potential nice perks of the vitamin. So that's the number I like.
Well, thank you so much. There are some other questions, or well, I guess I'll ask a follow-up to the vitamin D. When you look at your blood work, what is an ideal range of vitamin D? Well,
the lab you're checking, which anyone ordering would know, is called vitamin D 25 hydroxy. And your level ideally is above 30. Optimal bone health, they maybe think 40s or 50s is nice, but above 30 is good.
Thank you. We have some gender specific questions. A lot of your presentation focused on women, but we've had a few questions about if you have any specific advice or comments that you would offer for men that are suffering from osteoporosis.
Well, the same rules apply for prevention and treatment, really. The weight-bearing exercise, getting rid of any modifiable risk factor you can, the smoking, the drinking, boosting your diet with the calcium and the vitamin D. Yeah, I'm trying to think of something specific with it's the same across the board as far as what we recommend. Yeah.
And I see that there is a question about the why, and asking if there are personal trainers that specialize in osteoporosis work. So I cannot answer that question for you because I am not an expert in the expertise of all of our personal trainers. But if you contact me, I will put you in touch with our healthy living coordinator who can match you with the best personal trainer in the organization, whether that be for an in-person training or virtual. We also have virtual personal training for those that are not yet ready to return to the physical buildings. So please go ahead and get in touch with me if you would like to learn more about the specific resources that we have at the Y. And I can also follow up in an email with you all about that. So rather than following up like right away tonight, I might put a hold on it and ask some questions, and then I can give you guys some better resources tomorrow in that follow-up email.
Jess, I just remembered one thing on the male question. Actually, your testosterone level is something to ask the doctor about. If that's low, that would affect your bones. I don't know all the specifics of those symptoms of having low testosterone, but that is something that would affect your bone quality, and you should be asking your doctor if that has been checked.
Thank you for that information. Any other questions from anyone in our audience? We've got a couple thank yous coming in.
I recognize a lot of these names.
Well, if we don't have any further questions, are there any final thoughts that you would like to leave us with this evening?
I'm reading the questions. I don't. Okay. Do you want me to answer anything? No.
Yeah. Sure, go for it. Okay. Let's go ahead and answer those.
Spinal stenosis is different with osteoporosis. If you've had a compression fracture from osteoporosis, then that could eventually lead you into having some spinal stenosis issues. But technically, they're separate.
And then the one little question around IU compared to MCG.
I have not seen MCG for vitamin D. I have only seen IU, if that's the reference with the vitamin D. And then the calcium, of course, is always milligrams. Now, micrograms, MCG, if you see that with calcium, I don't think you would, but you just convert it to milligrams from micrograms.
All right. Thank you so much. And now those final thoughts.
I guess, yeah, just take good care of your bones and exercise and move. And oh God, this pandemic, we got to get off the couches.
And when you're ready to do that, we at the Y are here to support you on your movement journey. And we have a variety of other kinds of resources that we can connect you with as well, as a health seeker who is looking to extend your quality of life. So feel free to get in touch. Be sure to register for our next speaker series with SOS. Thank you so much, Lisa, for this really beautiful, informative, and generous lecture. I know that our community is really grateful for the work that you do, not only in the office, but also beyond that in terms of information sharing with our community.
Thank you.
So thank you so much.
You're welcome.
Good night, everybody.